I don't know if he's ready there or not yet. السلام عليكم Yahya. Do you hear us?
عليكم ورحمة الله وبركاته.
Hello Yahya, Dr. Hansha with you. So we can't see you here from here. So could you just explain us what you will do, and you can just inform us what's the case, what you have?
Who's this, please? Sorry.
Dr. Hanshel.
Dr. Hanshel. Good afternoon, everyone. And today we have a live transmission. It is AF case, ablation using the Farah pulse technique. With me here is Dr. Saleh Al-Basiri, my colleague, consultant electrophysiologist. Dr. Mr. Ahmed Al-Amri, our technologist. Nadeem from the company. We have our anesthesiologist. We have Dr. Khalifa from ECHO. He's doing transthoracic, and we have our radiographer and our nursing team. So Dr. Saleh will start presenting the case briefly, and we will get going.
Yes, good afternoon, everybody. This is a 55 years old male known to have hypertension and paroxysmal atrial fibrillation. This patient, he is suffering from attacks of episode of atrial fibrillation from the last 2 years, despite he is on medical therapy, including flecainide and bisoprolol. His CHAPA score 1. He was considered for atrial fibrillation, risk and benefit explained. He's today for BVI using pulse field ablation.
So here,
yeah.
Okay.
Yeah,
okay,
his physical examination is okay. Routine blood test is within normal range. ECG sinus rhythm, transthoracic echo, normal LV function, normally size, no significant valvulation. And this is his CT. Can we see CT, please? He's separated. This is rendering volume CT, short for pulmonary separated pulmonary veins, sizable veins. The right side 20 by 16 both, or approximately both, and the left side about 17, and the lower one is 16 millimeter.
Okay, thank you, Dr. Saleh. This is the camera, please, on. Can you see Dr. Al-Hanshel? Can you see the Farah wave catheter?
No, could you come closer, please? We cannot see you very well.
Okay, can you see it?
Could you zoom it?
I can't hear Dr. Al-Hanshel.
Could you zoom it, please? We cannot see you very well.
Can you see us?
I think there is some connection. There's Ayman here. I think there is some connection problem here. We cannot hear you. We cannot see. Do you hear us or not?
We can hear you.
Okay.
Hear the presentation, the case presentation?
Yeah, okay, we heard it already.
Yes. And this is, can you see the catheter now?
Yes, we can see the catheter, but if you come closer, it will be better.
Now we can see it in the main screen.
Okay.
It's okay.
Okay, so that's basically the catheter.
Okay.
And this is the Farah pulse system, and this is the Farah wave. It's a flower-like. We fix it, and we'll just get going. For the sake of time, okay. Connected, Dr. Saleh, please. Keep it flushing.
Flush.
Flush, please.
Can you move the zoom, please, to the patient? Yes, please.
Oh, off Zoom, please.
Yes, good.
Okay, just give me space, please. Flushing. Yes, I know. It's so Dr. Khalifa said that your delivery system now is above the mitral. That's what we usually do. Once we cross the septum, we advance the FARA drive sheath, which is the delivery system. And then we flex it down to be in the safe side. We keep it toward the mitral. So here, once we advance the sheath, we make sure that we did not introduce an air while introducing the system. So what we actually do is aspirate from the system. That's what I'm doing till I get some blood back. And they did not get blood yet, so I have to do it again. So this is blood back, and then keep flushing. Do you hear us, Dr. Hanshel?
Yes, we can hear you very well.
Yeah. Dim the light, please. Light off. You see the screen? You see the wire coming out of the sheath? So make sure that the wire does not go to the appendage. It seems to be going to the appendage. So I'll try to go. This is now to the right upper vein. Hold the wire, please. Hold the wire.
أول شيء السلام عليكم دكتور يحيى كيف حالك؟ أيمن خضرة معك.
Yes. هلا دكتور أيمن. Yes.
الله يحفظك. هل في طريقة بس نكبر؟ أيوة. Thank you. Done. That's it. We wanted to focus on the fluoroscopy.
Okay. So that's, you see the system, the faraway catheter coming out. And now try to open it. This is the basket configuration. You see the catheter in the right upper vein. Left upper vein. Can you see it? Can you see the
Clear.
EGM? You see the nice EGM? Are you ready? Okay. So, atropine, please. 0.6 atropine. Yes, given. Yeah. So we'll give the atropine. Make sure that it doesn't cause. Dr. Khalifa, can you please pull the probe? Just, okay, up. Yes.
Yahya, once you're ready, just before you deliver, just ask. We will ask him to get the EGM bigger, then we can see.
Yeah. See that? Put the EGM on the screen, please.
Yeah, this now is good. Right? This is good now.
Yeah, huge EGM. Signal. Atropine given. Okay, so the atropine given to avoid bradycardia, and I think we are ready for basing for case of bradycardia. Yeah. How much atropine given? Okay. Did the patient respond to it? Yeah, be ready with the other dose if we need it. So, okay, Nadeem, yalla, go ahead. So now we are delivering. Lock. What happened? See the signal? Dr. Ayman, Dr.
Yeah,
Naeem.
very clear.
Okay, yalla. It's almost immediately disappeared. Nadeem, when you're ready, yalla, go ahead. Okay, 2 delivery in basket configuration, and now I'll make a turn, and then I'm ready. Okay, go ahead. And again, once you're ready, and Nadeem. Okay, deliver. So this is for application on the basket configuration. Now going to the flower configuration. Make the wires stays stable. Trying to advance the sheet to make it more stable. Okay, so I'm happy now. Are you happy? Okay, so to make it more stable, we'll push the sheet as the recommendation of Mr. Nadeem. And I always listen to his recommendation, especially when we are in live transmission. Okay, go ahead. No, wait. Okay, I think one of them actually signed the name. It's a big vein. The left upper is actually a big one. That's why one of the splines. Okay, now it's better. You see the signal? Yalla, go ahead. Yalla, okay. The second, yalla, go ahead. Go ahead. Okay. Okay, we change the configuration. Oh. Okay, go ahead. Okay. Go ahead. So we finished 4 flower basket. I see no signal. We'll go to the other vein. Naeem, can you hear us?
Yes, I can hear. Can you comment how much adenosine you give and for the first vein? Do you give for all veins as well?
Atropine, we go
atropine,
600,
sorry.
Mike.
Sorry, how much was it?
We'll start with the left lower now on the basket configuration to start with. Can you see the left lower now? The left inferior? You think you are there? Still we're in a branch? Or?
Could you maximize the floor just to see the floor with you?
Okay. Yes. I'm ready. Go ahead. Okay. I think they should make the recharging time still. Go ahead. Okay, second basket done in the left inferior. We'll change the configuration again. We turn it. I'm ready. Signal disappear. Okay. Okay, go ahead. Are you happy, Saleh?
Yes, I'm
Okay.
still happy. Yes.
If Saleh is happy, I'm happy.
I'm always happy.
Okay, always happy? Yalla, we'll go flower configuration. Push the wire, please.
Yes, sure.
Is Abdullah Shehri around? Is he happy? There in the podium, Dr. Naeem?
Abdullah.
He's
No,
happy,
he's not
please,
here. I wanted to make Amin happy. This is
We
the
have
most
his friend
important.
Abdullah Sharaf is happy.
Okay. خلاص, Abdullah. So if you have any question while we are working, I'm ready for the
So how much
flower.
application you give for each shape, Dr. Yahya?
Minimum 4 in each configuration. Okay? So 4 basket, 4 flower, minimum. So total of 8 per vein. Yalla, go ahead. In most cases, to be sure, we give another 2 application, anterior and posterior. So we did 4. We did 2. We change. So we give it the catheter clockwise rotation, anterior, counterclockwise rotation, anterior. Then we did additional 2 applications. See the signal now. Okay, go ahead. Okay, disappeared almost. So minimum 8 per vein. Is that the answer your question? Yeah.
Yes, yes. Sir.
Naeem, go ahead.
Can you get the EGM bigger now again, please?
Okay. There's no much. Okay, you mean bigger the screen? You blew up the screen from your side, I think. Okay. Right. Now, how to go to the right side? We clock the catheter and the cheese together in the flower. Make it closer to each other and try to clock them. Yes. It seems it's not going easily. No, we don't want this.
Dr. Yahya?
Yes, please.
Yahya. So my question, so is the manipulation any different than a cryoballoon inside the left atrium, or it's like more or less the same?
I think it is the same, more or less the same, but I think it's easier to me. Okay. Give me AP. See, it's outside. You think it's in the
Yes.
right upper vein?
Yes. It's in the right upper pulmonary vein.
Okay. So we'll pull back. Dr. Al-Mahmadi, does that answer your question? I think it's even easier. What's the size of the left atrium, Dr. Khalifa, here? Okay, that's good.
Dr. Yahya, do you find doing CT scan before procedure is helpful at all in these cases?
I think it is. Did you see the CT scan? Actually, it tells you an idea how big is the vein. We already know that the left upper vein is a large one. And we know already that right inferior is a quite small vein. So it's very helpful. We are ready? Okay. Go ahead. Go ahead. Okay. Once signal disappear immediately in the right upper vein. Once you are ready, Nadeem.
Dr. Yahya, do you use contrast for these cases, like a lot of people they
I
are doing
don't.
with cryo?
I
No
don't.
need for that.
I don't use contrast. People, they do it if they don't do prior CT. We do CT in most of the cases. But even if I don't do CT, I just depend on passing the wire. We know the general anatomy of the vein. I don't use contrast.
Good. My
I
other
don't like
question-
free contrast injection inside the left atrium. Yeah, go ahead.
Thank you. My other question is about the diameter of the sheath which is going on the left atrium. What is the
Yes.
size of that sheath?
I think it's 14 or 7, the outer 16.8. Yeah, go ahead. This is number what? Yes.
Do you see the signals reconnect in between lesion applications sometimes?
I cannot hear you. We did 2. How much?
He's asking if there is a reconnection during application.
In between applications.
In between application.
So, if I understand your question, do we go back and recheck again?
No. He was asking that if in between applications you have seen a signal of reconnection of the vein. Any one of
If
the
we see
vein.
signal, we take it immediately. Okay, we do recheck it. As you see, like now we are, in the same time, we are trying to position our catheter, but we are mapping. If we see a big signal, we don't leave it behind. So that's one of the...
Another question, what is your approach for common os vein, if you have a common os?
It will make it a little bit difficult and maybe you need more application. So remember that, go ahead. Remember that absolute contact is not absolutely needed in such cases. So reasonable contact in the proximity of the ostium of the vein, I think is more than enough. Okay. No.
Yahya, I have just one question as well regarding the phrenic nerve
Right.
stimulation.
Go ahead.
Do you need to base
So
on the,
at the same time, we are mapping for any signal as we move. This is 2 more? Okay.
regarding the phrenic nerve stimulation? Do you need any phrenic nerve stimulation for the right side, or we don't use it?
No, it's not like what Dr. Naeem did this morning. It's not needed because it's extremely rare. Go ahead. It's actually, as far as I know, maybe one case or a few cases of transient phrenic nerve. Go ahead. Paralysis. It's not at least a known or common side effect of this type of therapy. So that's the advantage of pulse feed over balloon. In balloon, you see now this vein is isolated. If you want to try map more, we can spend a lot of time mapping, but I don't see any signal. Do you see any? No. This is where our catheter inside the vein, it is isolated. It's flat, no signal. Now we are trying to remember that vein is smaller. We said the right inferior is quite small vein, but we try to engage it, and maybe that giving a curve in our delivery system, it will help us. This is the vein, yes. Right inferior. Give us AP, I'll just to make sure. AP, please. You see, a wire Okay. Show us the catheter, please. Move. Not sure. It's in the vein.
Yes.
Not sure. Okay, Elio, please. It's a good signal. I think it could be in the body or in the vein. Okay, yeah, let's go ahead. Yeah, go ahead. Again. So any question? We are doing the last vein now.
Yeah, Dr. Yahya, I have a question.
Okay.
Regarding the size of catheter 31 or 35, it's
okay.
As per the size.
I really cannot hear. Please go ahead.
Hear me? Dr. Yahya?
I hear a question about the size of something.
Yeah, 31 this or 35. It's based on the diameter of the pulmonary vein, or
we usually use the 35. We usually use the 35 in everybody.
35.
Deliver.
Dr. Yahya, can you hear me?
Yes, please.
I noticed you're ablating not during pacing, but during sinus rhythm. Does that make a difference for you?
Ablating what?
You're ablating during sinus rhythm, not during pacing.
Yeah, we prefer to do it during sinus rhythm. This is the best. You can't do it during AF, but it's the best during sinus rhythm. Okay, go ahead. Yeah, that's basket. More basket. Nadeem asking for more basket. Yalla. Yalla, Nadeem. Okay, go ahead.
Almost signal, nothing.
No signal, as you see. Okay. The last two application. Okay. Okay. We need to turn. Okay. We turn, Nadeem. Yalla, go ahead. Okay. Again. Light on, please. Okay, was the last vein. We see really no signal. So, do you want to ask anything, or we are done here?
Yeah,
A couple of questions, if you, go ahead.
Yes, please.
A couple of questions. One is there any value to doing SVC, IVC while you're there? The other thing is, what sort of settings do you use in terms of energy? Duration sounds like 3 seconds, but...
I think the duration is a preset. That is the last question. Yeah. We cannot change the recipe of the application because it's preset. We have to use whatever been programmed in
so the voltage and duration are not adjustable?
Sorry?
Voltage and duration are not adjustable?
Not true. Not adjustable. In this type of catheters, no. We cannot do anything about it. We have to use whatever recipe the company recommend. And actually,
the first question was about SVC and IVC ablation. While you're at it, is there any evidence that it matters?
I thought about it myself in some cases, but I didn't have to use it. If you ask my opinion, if I have to use it one day, I will use it, but carefully. I am sure that isolation of SVC is needed in a particular case, but I'm sure there will be a concern about more concern when it comes to the phrenic nerve, because this is off-label use. The Farapulse is only approved for BVI so far. It's not approved for anything. And when it comes to the CTI line, the CTI people have done CTI line with the Farapulse. However, there is a report that you can cause some spasm, especially RCA spasm, which is transient and it recovers. We don't recommend using Farapulse in anything else other than BVI. We use it in persistent AFib to create a roof line, posterior wall isolation. All of that is inside the left atrium. and even isthmus line, left lateral isthmus line, but not in the right side. If I have to use it one day, I will tell you, Dr. Al-Khadra.
Thank you.
Yahya,
Naim.
do you check the veins once again after you isolate the right side? Do you go back and check the left side, or you stop doing checking?
So the recommendation is to check it while you are between the lesions, because at least a total of 8 lesions, you have enough time to recheck the veins. But after I go to the right side, I usually don't go back to the left side. When you go to the initial study, they actually do the whole thing and then take 3D mapping system and they map the left atrium. After a few cases they did in this manner, they found out that it's actually not necessary and it's not recommended. So you want to shorten your left atrial time as you can. So as you said, it's a live transmission. We take our time. Left atrial time is probably less than 15 minutes. And please, yeah. And patient is ready to leave the lab.
There is report in literature of hemolytic anemia in multiple applications. Have you seen any in your practice?
So I'm aware about this case report, and this has been with extensive application, RF application, not basically the standard ones. And even though I think it's very, very rare, maybe 1 or 2, as far as I know, I think it's not a concern for us.
Dr. Yahya, can I ask, because as you mentioned, the LA dwell time is very short. Do you wait for a therapeutic ACT before you start ablating, or once you are inside, you give the initial dose of heparin? Probably you need to give 1 more dose. But do you wait for?
I don't wait. The short answer, I don't wait. I give the appropriate dose according to the patient weight. Then I check ACT every 15 minutes, but that during the procedure, because you might spend 15 minutes or 20 minutes before you reach therapeutic. And that will increase your left atrial time or your total procedural time. So the short answer, I don't. I give the appropriate dose and then start. Now we are done. The catheters, this is the delivery system if you want to see it. It's outside the patient already. Okay. And this is the catheter. You didn't need to zoom, okay? Just okay. This is the catheter over the wire. We'll pull the wire out. This is the Farah pulse. Again, if you don't see it at the beginning of the procedure, it adjusts. This is the basket, and the flower is when you push it till the end. Okay. You need a wire to get the flower. Okay. And we are done. We are finished. If you don't have any question for us.
Any question from the audience? So for the sake of time, we thank you, Dr. Yahya, for this very nice presentation. Well done. We'll go to the next presenter.